Mozambique was the first place where we really tried to formalize this into a system that would then work at scale for as many people as possible.
Let's look specifically at HIV. Of course, before 2005, what you see is really quite horrific. That's an area where we need lots of innovation. So please welcome Dr. Tom Ellman of Doctors Without Borders.
I want to talk briefly about our experience in Mozambique in Southeast Africa, where MSF has been working with the Ministry of Health treating HIV since 2003. The focus on HIV has really been critical. Mozambique is one of the most heavily affected countries in the world. Around 10% of adults are infected. In Mozambique, patients were dropping out of care because they were having to queue for so long, coming every month. Most people with HIV just need to take a drug every day. So what we did was agree that they wouldn't need to come every month.
So we are challenged to get these low-cost drugs out to as many people as possible.
The initial community ART groups were actually self-forming. They met up with each other, they knew each other, and they would come to the clinic together to say, can we form a group? And then they would meet regularly at a fixed place in the community where the one who had been to the clinic that month would pick the drugs for the others, hand them round, and they'd fill in a small form. The individual benefits are very clear. People don't have to take time out of looking after their kids or working in the fields. Instead, they go once every 6 months, which translates into the health workers having more time to deal with problems when they appear. The social fabric, the mutual support that can exist within these groups is a very important advantage of being within them, adapting your approaches to the needs of the patient, not the needs of the system. All with this common principle that you trust the patients to manage their care the best they can, and you try and simplify things around their needs. People always respond better to someone they can identify with. They've become more able to come to terms with the disease, feel more comfortable talking about it. If we're to leave no one behind, we need to go much further. We need to adapt these systems to make sure that they work for people who can't pass even the first hurdles of getting tested and getting onto treatment. For the hundreds of millions left behind in conflict zones, in fragile states, for migrants and refugees, health professionals must be willing to give up some control, to share knowledges and tools with their patients. And we need to adapt the approaches for other diseases. Imagine what could be achieved if we put more power into these communities. Showing this can put control back into their hands.